So I am thrilled to be with you all here today to talk about newborn sequencing economics, understanding value in context. There will be 3 talks as part of this panel. I will help set the stage, and then Dr. James Buchanan will talk about HTA processes and the English perspective. Dr. Matthew Aujla will talk about the Greek context, and Dr. Sarah Norris will present the Australian context. And then we will conclude with moderated discussion, Q&A, and the survey that Nick mentioned. So when we think about economic value, this is always relative. So health economists are interested in understanding what is the incremental benefit or harm or cost of using genomic sequencing above traditional approaches to newborn screening. We also think a lot about the trade-offs between benefits and costs, but also equity and efficiency, which our panelists will touch on today. Generating health economic evidence is crucial to newborn sequencing implementation. So we've talked about the value piece. This is the in-context piece. We've seen this theme of harmonization versus localization emerge several times throughout the discussions today. And here we're thinking about what is the evidence that we need to generate from a health economics perspective to meet the needs of local decision makers and HTA contexts across jurisdictions, while also leveraging the value of ICONs as a consortium. So we also need to think about approaches that can generate evidence across the lifespan and perhaps fill gaps in uncertainty that exist in trial-based data today. So with that, I will turn it over to James.
Thank you very much, Hadley. I'm also not trusting my eyes, so apologies for the laptop. So my job today is to provide a brief introduction to health technology assessment and economic evaluation, and talk about how economic evidence informs healthcare decision-making in England with a particular focus on genomic tests. And I'll talk about harmonisation and data collection as well in the context of newborn sequencing. I've only got 7 minutes, so this is just an overview, but we can explore the topics raised in the panel discussion. So let's start with health technology assessment. Here's a standard definition. It's a multidisciplinary process using explicit methods to determine the value of health technologies at different points in their life cycles. And the ultimate aim is to inform decision making. Many countries around the world now have established HTA systems, or they're well on the way to developing these systems and programs. A key component of most HTA processes is the consideration of economic evidence, which is where we come in, because the key aim in HTA is to identify health technologies that, for implementation, that improve health, however you want to measure health, at an acceptable cost. And the economic evidence usually comes from economic evaluations that compare the costs and effects or outcomes of a new healthcare intervention with those associated with current clinical practice. It's a pretty simple framework, but it's quite powerful. So this is the 30 seconds where I get to train you all to be health economists. So information is collected on the costs and the outcomes associated with the new intervention, and similar information is collected for the comparator intervention. The difference in cost is divided by the difference in outcomes, and we get an incremental cost-effectiveness ratio. We can compare that to some sort of threshold value, and that suggests an adoption decision. So the key data you can see from that that's required is data on costs and outcomes of the new intervention and of current practice. You're now all health economists. So turning to England specifically, how is economic evidence used in the decision-making process for when the intervention in question is a genomic test? Many of you will have heard of NICE, the National Institute for Health and Care Excellence. Evidence on cost effectiveness is a fundamental part of the NICE HTA process. But NICE primarily, not totally, but primarily considers interventions that are pharmaceutical in nature. There's a NICE diagnostics assessment program that can, in theory, consider the value of interventions like genomic tests. But in reality, most genetic and genomic tests kind of emerge into clinical practice without any formal assessment of value. Beyond NICE, for about 20 years, we had the UK Genetic Testing Network, which made recommendations on introducing new genetic tests in the NHS. Their test evaluation process required information on potential cost savings from the use of these tests, but didn't really go too far beyond that in terms of thinking about outcomes and value. As the UK Genetic Testing Network was closed down, the 100,000 Genomes Project was approaching completion in England. That led to the introduction of the Genomic Medicine Service across the NHS. But the introduction of this service and specific tests within this service wasn't particularly informed by evidence on cost effectiveness from the 100,000 Genomes Project. Economic evidence was generated alongside the 100,000 Genomes Project, but this was more focused on potential cost savings from reducing the diagnostic odyssey rather than estimating cost effectiveness. And as part of the Genomic Medicine Service, we now have a National Genomic Test Directory as well. This requires information on costs and on cost savings as before, but again, evidence on cost effectiveness isn't mandatory. And then the final piece of the jigsaw, if you like, is the fact that we have a UK National Screening Committee that has its own requirements in terms of economic evidence that need to be satisfied for any new population sequencing program to be approved. So that's the HTA landscape in England that we have to negotiate as we start to think about implementing newborn sequencing into clinical practice. So a couple of slides ago, I mentioned that we need data on the costs and outcomes associated with newborn sequencing to inform the HTA process. Of those two categories of evidence, I'm going to put cost to one side for now because, obviously the costs of rolling out sequencing are fundamental decision making, but it's relatively straightforward to generate this evidence in comparison to evidence on outcomes. And the problem that we need to resolve going forward in the context of newborn sequencing is that different stakeholders value different outcomes. And if newborn sequencing is going to be implemented in an acceptable and in an evidence-based manner, we need to ensure we're collecting the right data to inform decision making. So, for example, NICE and many HTA agencies require data on outcomes such as survival or quality of life or combined metrics such as the quality adjusted life year. Conversely, many of the large population sequencing studies to date, with some honourable exceptions like BabySeq, have generated evidence on improved diagnostic rates but haven't gone beyond that particularly to think about survival and quality of life impacts and other impacts like psychosocial impacts. And on top of this, there are further benefits of sequencing that are valued highly by patients and their families. So the impact on well-being of shortening a diagnostic journey, psychosocial outcomes I've just mentioned, access to treatment trials, improved reproductive decision-making. All of these outcomes are important, and if we overlook specific outcomes in the HTA process, then any implementation decision is going to be on somewhat shaky ground. So, final slide, identifying the outcomes data we need to collect to build the evidence base for sequencing is important, but the further issues arise when we start to think about how we might collect this data. First, there's a lack of validated outcome instruments for use in children and newborns. There's also no consensus really on the most appropriate instruments to use, in particular when we're thinking about psychosocial outcomes and the personal utility benefits of genome sequencing. And given the huge number of conditions that could be considered within a newborn sequencing program and the small populations of newborns that have each condition, it's quite difficult to generalize the limited outcome data that does exist across conditions. But to end on a positive note, I think we can solve these problems, and the key is going to be making an effort to harmonize approaches to data collection globally and sharing data where this is possible. So specifically, I think we should be focusing time and energy on filling evidence gaps that aren't region-specific, so answering questions such as, is there a consensus that we can form on the instruments that are most appropriate for collecting data on health and non-health outcomes? What are the relevant utility scores for specific health states for parents and newborns across the whole life cycle, so before, during and after sequencing? And can we combine data across jurisdictions to eliminate evidence gaps related to outcomes in small local populations for specific newborn conditions? And I'll stop there, but looking forward to discussing further.
Okay, let's travel to Greece. First steps, we aspire to universally newborn genome screen Greece within 5 years. Of course, to be able to do that, we're going to have to show that we can create value in the Greek context. So I think it's helpful to start with where is the HTA, the Health Technology Assessment Policy in Greece today. So the Professional Society of Healthcare Economists and Outcome Researchers recently reviewed the status in Greece, and while Greece gets credit for adopting the initial model, HTA model, in 2018, there's still large room for enhancing both the processes and the structure. And if we look at where the HTA context is today, we can see that it's basically a pharmaceutical-only assessment process that doesn't have any publicly available cost-effectiveness thresholds. So, given the nascent state of the HTA in Greece, how do we think about who the decision makers are and how we can address the criteria that they have? So there's 3 groups of decision makers. The first is the payers, and this extends beyond simply the Ministry of Health. Philanthropy is heavily involved in both newborn and pediatric healthcare in Greece, and the national government is also working in collaboration with EU co-funded projects to impact healthcare. Now, the second group is the providers. So both for public and private hospitals, this will obviously impact both their capacity and their budgets. And from a public perspective, we're really talking not just about the patients of rare disease, but all citizens who will be contributing and potentially benefiting from this service. So if we go through the criteria of these decision makers, the first, of course, is being able to showcase the value created from a healthcare economics perspective, both from a budgetary and quality of life dimensions. But there are, from the payer perspective, I think 4 additional criteria that are important when we start to build the holistic value case in Greece. So those 4 include increasing positive demographic growth. So the government has made an investment in trying to grow the population. So there's a baby bonus program that's been launched in 2020. So each newborn, every family is subsidized with a 2,000 euro baby bonus. And then there's other dimensions. So the government wants to expand R&D and also increase international orientation. They have an objective to increase efficiency through innovation, meaning both digitization and increasing participation of the private sector. And then finally, we want to have, or the government sets out to have, an inclusive social safety net. So we have designed the First Steps program so that it reaches each of these dimensions. If we drill down on what's our process for measuring the outcomes for economic evaluation, we have a 3-phase process. So we're currently in the first phase, which is determining the current costs. So the second phase is modeling the cost benefit, and the third phase is collecting the real-world evidence to be able to prove out the model. Just briefly, in each phase, the inputs in the first phase is taking our disease list and understanding what the current expenditure is, working with the hospital groups and also the national healthcare system to try and come up with at least an estimated range of what the expenditure is today. Then the second step is our next phase of the First Steps Greece program, which is going to be both sequencing and analyzing 20,000 newborns. And the purpose of that will be to get a clinical incidence of genetic disease in the population. And then we'll transform that into our initial healthcare model, where we estimate the health technology assessment elements, both from a budgetary and a quality of life perspective. And then the final phase is the full rollout on a universal level, where we're tracking both the interventions and outcomes over a longitudinal period so that we can test and prove that the healthcare economics work. And this, again, is part of the first and primary criteria, but it has to be part of a more holistic value proposition that we go through each of the dimensions that I mentioned in the decision maker criteria.
Hi, everyone. Thank you to our previous speakers. My name's Sarah Norris. I'm an Associate Professor of Practice in Health Technology Assessment at the University of Sydney. And James gave you an introduction to health economics. I'm going to take you up to the next level, and I want to really explain what it is about using genomics in newborns that is really challenging how we approach health economics for this particular technology. And also, there's actually been a lot of discussion today around equity, so I want to talk to you as well about potential ways that we could explicitly consider equity in the health economic evaluations. So I want to start by acknowledging that the main campus of the University of Sydney stands on the unceded land of the Gadigal people of the Eora Nation, and I pay my respects to elders past, present and emerging. And I also acknowledge any Aboriginal and Torres Strait Islander people here today. These are my disclosures. I should have also added a disclaimer, which is, even though I'm a member of the Australian Medical Services Advisory Committee, which is the equivalent of NICE in the UK, the views expressed today are entirely my own and should not be construed as representing the views of the committee or of the Department of Health. Okay, so I sit in a Centre for Health Policy and Economics. So when I started thinking about this presentation, the obvious place for me to start is thinking about the relevant policy context, because fundamentally thinking about the use of genomic technologies in newborns is a health policy question. So in terms of Australia, we have a relatively small population of 27 million people, so that's about 1/10 the population of the US. And we are dispersed across a very large geographic area, so 7.7 million square kilometres, so that's about 80% the size of the USA. So we have an incredible geographic spread of the population. Most of the population is located on the coast. We also have an incredibly diverse population, so approximately 3% of our population identifies as Indigenous, and we also have 40% of our population having non-European ancestry. So all of these factors immediately, I think, should be flagging that there are equity issues here in terms of access. We have significant access to all healthcare, not just to newborn, not potentially to newborn sequencing, but to all healthcare, but because of geography. And then we also have the challenge around the diversity of our population. In terms of our healthcare system, we have a universal access scheme, which is called Medicare, but every single Australian can access Medicare, and in addition to that, you can opt in to also have private healthcare. Importantly, all of the population screening programs in Australia are fully funded by government, and this includes newborn screening, but this is what's unique about newborn screening in Australia is it's actually funded and delivered by the states. So we're actually a federation of 6 states and 2 territories, and we have 5 separate newborn screening programs. Might be something you're not all aware of. And in fact, until recently, each state determined essentially what was on their panel, and so this led actually to what was framed as a postcode lottery. Depending on which state you lived in, you had access to, you were screened for different conditions. So this actually became a political issue at our most recent federal election. So equity is front and centre in the context of Australia. I also just wanted to acknowledge that we have a number of relevant policy documents. I'm not going to go through them all there, but documents that speak to screening in general and specifically the use of genomics in screening in programs. So this is our current approach to determining what conditions are screened, and I'm not going to go through this in detail, and in fact it's so hot off the press it hasn't actually really started yet. But in the middle there, we have a step now where conditions need to go through a formal health technology assessment phase. So that is being undertaken through MSAC, the Medical Services Advisory Committee. And as James indicated, certainly in the case of MSAC, all of our full HTAs include a health economic evaluation. Okay, so when we think about the evaluation challenges for newborn screening programs in general, these really all flow as a consequence from the fact that we're talking about rare diseases here. And we've heard about this today, and we've heard about it from the other speakers. And so that paucity of clinical evidence flows through into the health economics, because it means that we have less data to populate our models, which means that those models are less robust than we might otherwise want them to be. And then we've also heard mentioned today about implementation and the importance of considering that as well as part of the overall evaluation of whether you include a new condition. What I really want to hone in on today, though, is thinking about actually we need to conceptualise, have a much broader conceptualisation of the costs and outcomes that are included when we are considering health economics for genomics in newborns. And this slide is really just, again, I think we've heard about all of these aspects today at some point. So, you know, specific challenges when we're thinking about incorporating genomics into a newborn screening program. And I know there has been discussion here today about the difference between newborn sequencing and newborn screening. I think hopefully given the context of Australia, you'll understand I'm very firmly coming from the point of view of a public health perspective here. Australia is a very egalitarian society, so I think there is an expectation that, as well, that if screening is provided, it is provided for everyone, and that also if the public sector is funding screening, then the public sector will also fund the treatments. So that's something we can maybe pick up on in the discussion, because that's not something we've really heard today. So I just want to go into thinking about how we conceptualise potentially the expanded, what I'm thinking from an HTA perspective, these are expanded definitions of benefit, and they're probably all very familiar to you in the sorts of things we've been hearing about today. But all of these aspects, if we take a health technology assessment perspective, and we look at those five potential definitions of benefit, actually only one of them would sit within what we define as the base case for a health economic, for an HTA. So the base case is the set of assumptions that are preferred for that particular decision maker, and then they conduct supplementary or additional analyses around the base case. So importantly, the only thing here that's being considered in the base case, certainly in Australia, would be the direct health impacts to the newborn. So we can see that those other impacts are important, but they're considered as secondary benefits or supplementary benefits. We have a similar story when we start thinking about the costs as well. So these are all the particular costs you might be thinking about. In our project that we're doing, we are agnostic to whether the genomics is being used as a first or second tier test. We really just don't have a view on that. But again, when you think about how these would then be placed within the base case for a health technology assessment, only those first three costs would actually be in the base case. So the cost of the screening, the cost of the diagnosis, and then the cost of the medical care, which may or may not include an advanced therapy. And then in addition to that, the health technology assessment perspective would also include the opportunity cost. So that's basically the cost of funding the use of the technology for this purpose, and those funds which could otherwise have been spent in another part of the health system. And this is my final slide, just starting to think about possible ways that we could actually be including equity in health economic evaluations. This is just a bit of a brainstorm. So we could apply a higher weighting of the QALYs, so that's the quality adjusted life years that James mentioned. And we could do that for priority populations. And in fact, newborns with rare diseases can be seen as priority populations. But there's a challenge with that. How do we derive and apply those weightings, and how do we interpret them when we're looking at the cost effectiveness? We can do things in the model like vary the uptake rates of screening, the rates of diagnosis, and the treatment to explore the impact on cost effectiveness. But we still need to understand how those specific dimensions of access are impacting on those particular domains. And then there's a fancy new methodology that's actually being pretty much developed here in the UK, which is called distributional cost effectiveness analysis. This is still a very new methodology, but it does require a lot of data. And so as we all know, that's potentially very challenging when we're considering rare conditions. So might not be necessarily applicable or useful in this situation. And then if we take a more qualitative approach, we could consider that we only screen, you know, if the health system has the capacity to care for all individuals who are identified. I know that's an opposing view to the one that we heard at the end of the session before the break. And in doing that, we need to consider the holistic care. So it's not just the care of the newborn, it could be surveillance for the newborns, and it could also be care and surveillance for their biological relatives. And it might be that we could accept a higher than usual incremental cost effectiveness ratio for these priority populations. And you heard James mention the threshold, and the UK certainly has a threshold for funding. However, Australia does not. And in fact, it's very hard to know internationally what is an acceptable level for a cost effectiveness ratio for newborn screening, because we actually don't have too many to hand to even inform that discussion. Thank you. So that's the end of my presentation.
Okay, so I think we will go straight to audience questions in the interest of time.
Hi, wonderful talks. Thank you very much. I should know more of this from working with you, Hadley, and in Boston, but I'm a little naive on how do you factor in if the crazy plunging costs of sequencing, the potential we all kind of expect for automated analytics and even to some degree, hopefully automated decision support into these economic models? It would just seem to be very hard to predict what's happening. That's sort of, and the second part of that is, by any measure, it doesn't seem like it's going to be obviously cost effective, you know, at this moment in time, and yet here we all are moving forward. How do you think about that?
Do you want to go? So in terms of the cost of the sequencing itself, so absolutely, it's an uncertainty. So you would test that right with what we call sensitivity analyses. So you would vary it around a sensible range of potential values and see what impact that has on the modelled result. Importantly, the cost of the sequencing itself is really only a small component of the overall cost, though, because it's about clinician time, health professional time. That's usually where a lot of the costs arise. So that was the first one. That was. Sorry, what was the second part of the? Why we're all here? Very good question. So, well, you know, I can't really speak about the actual cost effectiveness. I think there's definitely, certainly from an Australian perspective, there's an acceptance that screening and treating and testing in rare diseases has merit in and of itself. And so there's been a real push, certainly with genetic tests more broadly, to make sure that they are reimbursed for rare diseases, and so that they aren't being unnecessarily penalised because of the difficulty of either getting the data that we've heard about already, or because they might actually have a very high cost effectiveness ratio. And so this is actually one of the reasons Australia doesn't have a threshold. We actually believe that there are instances where, in fact, quite a high ratio could be acceptable on balance given the unmet clinical need. So all of those factors go into the decision making. It's not purely on the basis of the ratio.
I can add a little to what Sarah said. On the cost side, you know, I was delighted to see the usual cost slide appear earlier with the declining cost over time. It appears every time in these sort of sessions. It would be sad if it didn't appear. One day it won't appear. But as Sarah said, we've been told for a long time that costs are coming down, but when we do the micro-costing studies that include everything, we don't see that emerge, at least at the pace that people believe that costs are coming down. So I'm probably on board with you in that the AI, etc., will reduce the bioinformatics costs, but the speed at which that happens, let's see how quickly that happens. The other thing to add is that in terms of why we're here, as health economists, we obviously we'd like to think that decisions regarding use of interventions like sequencing in clinical practice are solely made on efficiency grounds, but we're not really kidding ourselves. We know that that's only one factor amongst many. In the UK, we had the 100,000 Genomes Project, and that evolved into the Genomic Medicine Service. That wasn't informed by a robust cost-effectiveness analysis. There's broader benefits to having a genomic medicine service in terms of the UK having a thriving life sciences industry and everything that goes along with that. And I think that's a consideration as well. So I think in terms of why we're here, it's not just narrowly focused on getting some cost-effective screening into clinical practice, but there's a bigger picture, and that comes through a little bit in terms of the aims of the generation study, which go beyond just looking at the cost-effectiveness of sequencing. There's a research angle to it as well.
Who's going to go first? Shall I go first? Because I started. I've been to quite a number of discussions about how we assess the health economic benefits of genomics. And I'm always struck by there being multiple different presentations of how we do that in the same discussion. And I was really interested, James, in this idea that you'd outlined about could there be a means of bringing some of these principles together, looking at a global level. Is that ever going to be possible, that there is one way of doing it?
No. And nor should there be, because every country that has a HTA process does things differently, and HTA processes reflect the values of particular countries, and the things that what we do in the UK is different to what is done in the Netherlands and Canada and Australia, and what isn't done in the US to a large extent. So there's no reason why we ought to be doing things the same. But what we can do is harmonise things like data collection, and within the confines of privacy and data sharing laws, try and share that data across jurisdictions, so that even if we're not ultimately all using the same data to make the same decisions, it's fed into the process. So I think that's an important thing to consider going forwards.
So in the States, we like to spend more money than we have, which leads to lots of interesting conversations, and then we rely on the rest of the world to help us out. So you can envision that early on in the process, we'll spend a lot of the money that we spend will drive improvement in quality of life for humans and citizens of the planet. But you could envision that we get to a certain point where costs of care lead to a lower relative improvement in quality. So how do health economists think about getting to the point where we're spending too much GDP on healthcare? I mean, these are arguments that we have all the time about how many dollars to spend on health. How do we approach the maximum end? We're in the early part of the curve, but how do you get to the point where you're arguing about when we're at the other end of the curve and now we're spending too much money on health? It's a different question. It's a tougher question.
Yeah, what is the right amount of healthcare spending is maybe not one that...
No, I think they're sort of conflating two things there. So one is the health economics, which is really, as James was explaining about allocative efficiency. So is it cost effective to spend the money for this particular purpose in this situation? Whereas what you're also then talking about is the financial total budget impact. And certainly one thing Australia always does is we don't only consider the incremental cost effectiveness ratio, we also look at the total likely budget impact. And it might be that the cost effectiveness ratio is actually acceptable, but actually it's the financial impact that's not acceptable, and so it might not be funded because of that. So I think you need to look at both things. They're different sides of the same coin, but they both need to be considered. Yeah, and how that's a societal decision. You know, that's yeah, and spending more of your GDP on health doesn't necessarily buy you more health outcomes. So yeah, it's just a reality.
Christoph from Sydney again. As someone that exclusively treats rare diseases as a metabolic doctor, I come across new diagnoses that I've never heard of every year, every month. How do you put a condition where there's no data, where there's a black hole, into a health economic model?
I think to answer that, I think that there's a broader consideration that we all need to get more comfortable with uncertainty, I think, and we're going to be generating evidence, we health economists globally, on the cost effectiveness of newborn genome sequencing, and we're going to be doing that in the face of, you know, deficiencies in the evidence available. We won't have the long-term data on outcomes that we need. So the data that we use is going to lead to estimates of cost effectiveness that are uncertain. We need to, as health economists, do a good job of communicating that uncertainty, and decision makers, I think, need to become comfortable with making decisions under increased uncertainty. I think this was mentioned. Was it Mike Richards, I think, was talking about this earlier? Because ultimately decisions still need to be made. Not making a decision is still making a decision. You know, those situations are likely to arise more frequently, and we need to get comfortable with them, I think.
I think also we can learn, you know, there'll be themes that emerge across different conditions. So, you know, if the phenotype's similar, then we can, health economists also very comfortable with assumptions. It used to scare, because I trained as a medical scientist, and it completely freaked me out when I started doing health economics. Where's your citation? Oh, just to make that an assumption. So I think we will, as we sort of develop a library of economic evaluations of different conditions, we'll start to see what those themes that emerge. The other thing that I just wanted to pick up on, and it was in the definition of HTA that James put up in his slide, which is that it's across the life cycle of the technology. So also HTA shouldn't just be do it once, set and forget. It can be reassess, come back at a later date when you've got more data, or you've got data from a similar condition that you could then use to populate the model for that condition, and reevaluate it. And it might mean that some things then get supported that weren't previously supported, or it could mean that some conditions are actually removed. I mean, you know, that's a possibility as well.
All right, I think we have time for one more question.
Yeah, I would reinforce this. You know, the initial question was about the cost of the sequencing, which was minimal when you consider the clinical care and the delivery system. But what happens, you've already done the sequencing. You can look at it 10, 20, 30 years. That sequence has been done. You've already paid for that. And so the economy of it, look at that over time and see what the value of that is. And I'm sure you'll find that very cost effective. And the chronic disease at age 30, 40, 50, and having the sequence of finding out the causes of those chronic diseases and preventing disease progression. And so I'd like to see your model with something like that. Again, you sequence a newborn and see what kind of diseases. And,
I think there's also some interesting questions around reanalysis and the optimal period of time in which to do reanalysis of that original sequence data, or just resequence people. Right?
Well, and also the time value of money. So the return on the value needs to be within the cost of when the high expenditure of sequencing happens.